Welcome everybody to the Early Corporate Forum. What I'm basically going to show is a lot of clinical data, radiographic data, histologic data on why I use bioactive materials, specifically the BioXclude membrane and some other bioactive grafts and growth factors to accomplish what we as periodontists need to do. So as part of that, we have to think about what our role is in patient therapy. Because unfortunately, patients generally don't know what it is, and most dentists really don't care what it is because they just want to keep the patients in their own offices. So when we think about what we do, with a lot of our patients, they come in challenged. Most of them don't lose a tooth or multiple teeth because of an accident. They lose it because of caries, because of poor plaque control, because of systemic or genetic issues, smoking, diabetes. So if they have those and they lost their teeth or lost bone around their teeth, we know it's a fight to either bring it back, or if we place an implant, then they're at risk of losing bone around their implants. And if we look in historical terms, and we go back in the data in the archives and think that humans and teeth are 4.5 million years old, and scientific data around implants, whether you go back to the early Brownmark bone studies or Lenny Linkow and Sheshev, we've only been looking at implants for 70 years. So to me, I would rather do my best to grow bone around teeth than to try and regrow it around implants, which just isn't as predictable. So, and we're going to show a couple of cases, a number on perio, and at least one where we or two where we try and grow bone around implants as well. But again, to me, if I'm using bioactive materials, it really tips the scale in my favor, and it can help overcome some of the patient's issues. So how do we do this? We do this by reading the literature. We're periodontists. What we do is based in literature. We do it based on science, and we do it by interacting with each other, by seeing and talking to other people about what works and what doesn't work, not just what's in the pretty pictures. Because everybody's going to show pretty pictures, but you want to know what really comes through and works with patients and what doesn't. So like a number of people who teach, I wear a lot of hats. I only teach 1 day a week. I teach in oral surgery, but I work with perio, I work with biomaterials, I work with a lot of people at NYU, projects in India and in Spain, and like a lot of people, just try and do a lot to figure out the science of what's going on. Alan Farber, a good friend, started a new organization, International Association of Dental Specialists, really cool to try and get the word out eventually to the public about what dental specialists are. So I'm going to just show you an overview of some of the cases that hopefully, if I talk quickly enough, we'll get through. So this is probably a patient that many of you have, someone who is allergic to floss and allergic to toothbrushes. But if somebody like that has 7 to 10 millimeter pockets, and forget about wanting an aesthetic result, but wanting a result that's maintainable, what do we get if we take out the teeth? What can we possibly get that she can maintain if we take out the teeth and she now only has 1 millimeter of bone above the sinus and she has a 2-to-1 crown to root ratio and never brushed her teeth? What is going to make her say, oh my God, I just spent $20,000, I better brush my implants? It's never going to happen. We all, those of us with very large foreheads that start back here, we know that is never going to happen in 1,000,000 years. So another patient, real sweetheart of a guy, but losing his ability to brush, failing perio, some failing endo. So what do we do here? Do we take out one or both teeth and then risk vertical ridge augmentations? If we take out 19, what's going to happen to the bone on the distal of 20, no matter how we graft it? So let's think about what we need to do there. This, I think, is the case we're going to end with, although it's not finished. What would you do here? How many teeth are you going to take out? And if you take them out, what are you going to replace them with? And if you replace them, how many surgeries is it going to take you to predictably get some sort of an aesthetic result? in a patient who we know has no buccal plate, some sort of missing lingual plate, and possibly a perioendo lesion on the adjacent central. So these are just some of the challenges that I know we all see. Here's an easy one, just a fractured tooth with the endo failure. How about this one? A bulimic patient. We know she's not going to heal well, and we're going to look what happens when we use a bioactive as opposed to a non-bioactive graft in her. And this patient, 3-pack-a-day smoker, what happens when the single simple extraction and the graft fails? How long does it take, and what does it take to do to get that right? And how about this patient? None of us ever make judgments of our patients. None of us who teach ever see patients that come in like this and say, oh my God, this patient must be. Because if you did, you'd never guess that this was my cousin, who's a very prominent OBGYN. She just happens to be scared to death of dentists. So she would drive the 10 hours from Ohio to my office when she finally realized she couldn't chew so that I would treat her. So if we don't rebuild all the bone around these teeth when they come out and give her something that she can keep clean that's not going to trap food and plaque, she's going to lose whatever implants we place. So let's start with my cousin. On the right side, we have intact bony walls. I don't need to augment. I need to have a graft that's going to give me bone quickly. I'm going to add a growth enhancer that's going to be angiogenic and osteogenic. That's going to help me fill the sites. But I'm going to want a barrier over it that's going to protect it because I'm not seeing her for 3 months. So the graft mixture that I'm using is DFDBA and calcium sulfate. What John Sotosanti and David Anson and so many others showed us over the years will give us good solid bone quickly in 3 months. We know that the calcium sulfate, whether it's single or biphasic, will give us the slow release of calcium sulfate. Again, angiogenic, osteogenic. But what I want, and this is actually the barrier from the other side, is the amnion-chorion barrier over it. Because that's going to ensure that even though I know that the body will heal over calcium sulfate if I put a calcium sulfate barrier there, with her being 10 hours away, I don't have to worry because she will epithelialize over that calcium sulfate barrier. So here on the other side, where she was missing part of the buccal plate and where she was missing bone, and here's after 14 was taken out, where she was missing bone close to the sinus floor, we used FDB and calcium sulfate. The reason I added FDB is because it being mineralized, the scaffold would last longer and give me more time for the endothelium and the blood supply to come into the graft before it started breaking down, and for that to bring in the osteocytes to deposit bone on that scaffold that's in there. But again, using the BioXclude would help ensure that I would keep all that, and look at all that extra height we got. Remember, that was the native bone. Just a fraction of a millimeter. All of that extra was just from the simple extraction and proper manipulation of the biomaterials using the bioactive barrier. So here's what the left side started as. Looks like the right, but much closer to the sinus floor and with no buccal plate. So again, mineralized, slower resorbing graft there. And we get the implants in and loaded, and we get vital bone. Not the best vital bone. So she may have some metabolic issues going on there as well. She has a little bit of osteoporosis. So in these patients, I wait longer just to be sure. I'm not in a rush to place an implant at 3 months and have it fail. And on the right side, there we have the original defects. DFDBA and calcium sulfate with the BioXclude over it. And that's what it looks like fully healed. I didn't need to make the ridge wider. I didn't need to push the envelope and add volume. I just needed to get everything in there so we could get implants placed, eventually uncovered, and then restored. So we start there, implants, restored. And she's maintained this for about 11 years with no loss of bone. And that's the DFDB calcium sulfate side. No residual graft. The graft reossifies the DFDBA in the presence of calcium sulfate. So let's look at Ali, our bulimic patient. We know from the CBCT that there's very thin to absent buccal plate on half of those two lower premolars. We know we're missing bone here, so we're going to need to do a ridge augmentation and fill a large socket. So I can use dense PTFE and I can use amnion-chorion. So I'm going to use both. I learned from Stu Fromm, if you can do more than one thing, you can do a study. So let's look and see what we get. So there are the premolars showing the dehiscence defects and the first molar showing the site collapse and even dehiscence on the buccal of the second molar. So, Regeniform, DFDB, FDB, and calcium sulfate. DFDBA putty. Dense PTFE, BioXclude. What's the first thing you notice about the BioXclude is it has no memory. It's going to stay right where you put it. So one of the advantages of putting it here is the Regeniform is what's making the shape. It stays as a putty. And I have the height maintained by the lingual plate and the distal buccal. Everything heals, and that's the graft from 18, that's the graft from 19. On a bulimic, we got really, really good bone. But what do we notice here? Where we didn't have the bioactive graft, didn't have the bioactive barrier, the bone was so weak that Astra implant in the anterior walked out to the buccal, just making the osteotomy, and from that little flare. So the bone wasn't even strong enough and stable enough after 7 months to maintain its strength to keep the implant where I wanted it. So yes, we got the implants in, we got them loaded. We had, at this point, a long time ago, custom-milled abutments and cemented crowns, and she hasn't lost any bone on it. But where we used the bioactive barrier, we got much better bone healing underneath, better volume, better density, and better ability to keep the implants where we wanted. So what about Frank? Easy, simple, rotate out the central, mineralized cancellous allograft, calcium sulfate, everything looks beautiful. Or does it? Or does it? So, we all know about site collapse. 30 to 50% width, 1.35 to 2 millimeters in height. Implant goes in, implant is stable, implant starts to look funky, lateral starts to look funky. My very good friend, my mentor, my colleague, my patient, my neighbor, Harold Sussman, has written a number of patients on periapical infections on adjacent teeth going to implants. That's what happened right there. 10 blew an abscess, knocked out 9. And when it knocked out 9, it knocked out 9. Took out part of the buccal plate, took out part of the palatal plate. It blew the whole thing. So when I went to graft 10, we had to regraft 9. So I figured, piece of cake. Mineralized allograft, normal collagen barrier, everything is cleaned out. No problem. Graft, we put collagen, we put a titanium reinforced PTFE with a tack on the lingual so it's stable and it doesn't move and everything will be fine. That's what we have on the CBCT. Because there was residual infection. He healed so poorly from his poor vascular supply that although we got enough bone on 10, that's what the bone looked like on 9. He still had a draining fistula out to the palate. It never healed from the extraction because of his weakened immune response in that area. So even though it looks good, that's all junk. It's all still graft encapsulating connective tissue. So why would I use the same material again? Why would I put the same DFDB with the same passive barrier knowing it didn't work the first time? So I'm going to debride it. I have the same hole I did before, nothing filled in. I'm going to take a PRF block, which is going to be more anti-infectious and hold its shape, get it where I want in the ridge. And again, we know from Rick Myron, we know from Joseph Chacroun about what PRF can do, whether it's the LPRF or the slow speed concept of Rick. It helps us with our triad of cascade, but I'm going to use a bioactive barrier. Growth factors, binding proteins, anti-infectious, all of this is in the literature. I'd rather show you a lot of cases than bore you with 100 articles today. You can get the articles from my website and from the Snoasis website. But again, just drapes right over the top of the PRF block. We know it'll release growth factors, which can help stimulate healing. That's from the PRF, and that's from the amnion-chorion. We can get everything we need right from there. Angiogenic, antimicrobial, and now look what we have. Now we have bone. Now we have almost 10 millimeters of bone just by changing the barrier. Because if we look carefully at the PRF articles, the 3 studies that are done on bone volume shows no difference in bone volume and bone quality if we use PRF or if we don't. So we give a contour graft. That's what the porcine allograft, xenograft will look like over time. We do everything we can to keep him clean. We give him that device so he can brush around it. Implants get loaded. Thank God he has a very, very low smile line and no aesthetic demands. But those have been in there 10 years with no problem. Okay, Maggie. Maggie is a sweetheart. Maggie actually started her clear aligner therapy 6.5 years ago and got through 2 trays. So we know she's as compliant about ortho as she is about perio. So we know she has all these defects. So what are you going to do? The 3rd molar has to come out. She has furcations. She has pocketing. She has bleeding on probing. Do we have in the literature any predictable way to save those teeth with vertical defects? Number 1. Number 2, yes, I have every laser known to mankind. If we try and do closed root planing with or without a laser, are we getting all this stuff off the teeth? Not according to Stamba, not according to anyone else. Yes, maybe if we have the perioscope and we spend an hour and a half just root planing this section. So what do we have bioactive that we may be able to put in there to overcome the challenges that she's going to give us? So that's what we're starting with. In my traditional perio, that's hopeless, 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 hopeless. So 10 millimeters, 9 millimeters, everywhere you want to go. Bleeding everywhere. So again, if we take them out, we're going to have 1 millimeter to 2 millimeters above the sinus, have to do sinus grafts, have implants with long crown to root ratios that she's going to build a ton of plaque around, and she's going to lose them too. To me, that's not acceptable. So I'm going to try something on her. I'm going to open it up just to the crest. I'm not going to even elevate a flap beyond the crest because I don't want to damage the blood supply. I don't want to risk the flap migrating apically. I'm going to use that little bit of attachment at the crest to help hold the flap where it is. And I'm going to try periodontal supraalveolar with no bone to give me progenitor cells grafting. So I open, I root plane the crap out of it with hand, CHS, cold hard steel. I'm using my piezo scaler. I'm getting in there. I'm going to use tetracycline to treat the root surfaces, and maybe just in case I missed a bug or two, the tetracycline may get rid of it. And then I'm going to take the most bioactive bone graft that I can put in there. Most bioactive bone graft I have is going to be that tooth. So I'm going to take the tooth, I'm going to clean all the calculus off it, all the soft tissue off it. I'm going to put it in my Comedabio Smart Dent and Grinder. I'm going to make tooth powder, which Marshall Uris told us 57 years ago has BMPs and other growth factors in it. I'm going to mix it with cancellous allograft. Cancellous, because this is slow resorbing, I'm going to use this as a better scaffold. No PRF, she won't let me draw blood. I have nothing to hold its shape, just the particles themselves. I'm going to stick the particles in there. I'm going to drape BioXclude over it. One piece of BioXclude is going to go over the third molar and the distal of the second molar. All those other skinny pieces are going to go interproximally. You don't have to cut, you don't have to trim. You have to use 2 wet or 2 dry instruments because it's going to stick if you only have one of each. So there's the graft. There's literally the barriers laid across the top, and then we just get them a little wet and move them up apically so that it drapes over. And suture, simple interproximal sutures. What's the most part about this? Hope and pray that it doesn't get infected. Because if it gets infected, she loses everything and all the teeth. So what's bioactive? The dentin is bioactive. The BioXclude is bioactive. It's going to give me growth factors, anti-infective capabilities. If there's any part of my flaps that hasn't sealed with my sutures over the graft, the body will epithelialize over it. It'll epithelialize anything over the socket that I haven't tried for primary closure. We know that from Dan Holtzclaw and other studies. That's 3 months. We are at the CEJ. We have everything closed across. At 3 months, she had actually brushed her teeth. No sensitivity. I'm not probing it yet because it's only 3 months. So that's what we started with. That's the initial schmutz and all the plaque and calculus. That's debrided. That's the initial graft on the left. 5 months, she stopped brushing her teeth. My faith in humanity is restored. That's just from one interproximal area between 5 and 6. That was probably just what's left of her breakfast. But that's at 5 months. That's the original bone. That's the original bone. She has 3 to 5 millimeters of new bone, interproximally with no progenitor cells, no alveolar bone nearby anywhere. So yes, we still have her coming in every 3 months. And my hygienist takes out 10 pounds of stuff. But even at 5 months, the graft is becoming vital bone in an area that had no progenitor cells, because we're using a bioactive graft, and most importantly, we have it covered by a bioactive angiogenic anti-infective barrier. And yes, I have about 13 of these cases put together that Ron Nevins is going to help me get together and in a really legible format so we can put it in IJPRD. They go from 2 to 9 millimeters of vertical bone growth. So, Simple extraction. Can't put an intermediate socket implant there because you're going to have totally different alveolar volumes. And where would you put the shoulder? Tooth comes out, atraumatic extraction like we all know how to do. We're not taking it out with a cow horn because we're not going to destroy the buccal plate. And that's why it failed. So we debride everything. We make sure the site is fully healed, fully cleaned. In this case, to make sure we got in with diamond burrs because it had been painful for so long, I wanted to even take out some of that apical bone to be sure I could leave a clean, healed site. But again, as we know, although we don't really have papers in the posterior mandible like we do in the premaxilla, we know often the buccal plate is thin. So I'm going to take my allograft. I'm going to make a PRF block to hold its shape. Not so much for the anti-infectious capabilities, not because it's going to enhance bone. I'm not going for primary closure because I know the BioXclude can be exposed. That's why I don't have to elevate flaps. Once we elevate flaps, we cut the blood supply. We're going to lose more bone, more bleeding, more pain. If I need to, if I'm concerned about the patient, I'll put PRF over it. I'll put collagen over it. I'll put something not for GBR. I'll put it to keep the patient away from it, to keep the patient from damaging the site. And again, not trying for primary closure. Because even if that PRF is gone in a week, my BioXclude will have had its magical effect in that time. So again, angiogenic, the growth factors and everything. And what do we see like we used to see in the old days of cytoplast, the dense PTFE? Only this is bioactive and doesn't have to come out and helps our healing, doesn't just protect the blood clot. So we get an increased zone of keratinized tissue. We get no pain. We get a patient that heals beautifully over time. And we have literature again to back it up. And again, all these articles are available on the Snoasis website. But again, lots of advantages of the BioXclude. Anti-infective, angiogenic, binding factors, growth factors. It gives you stuff that no other barriers will give you. Again, a couple of hints. I like to keep them covered if it's larger than a premolar site. You don't want your patient to rinse with mouthwash or salt because the barrier can interact with the ions in it. And like I said, I don't really care what I put over the barrier because it's just acting as a scavenger. So another patient, barrier over the extraction site, not going for primary closure. A little piece of PRF, just something to ensure the patient feels with their tongue and their toothbrush that there's something there, and look at all the keratinized tissue we get. And it's not from the PRF. I'm sure a lot of you have used PRF. That PRF is gone in a week. It's not going to stay there like a connective tissue graft and give you more keratinized tissue. Again, more studies showing how well it works to preserve and enhance gingiva and enhance bone formation. Better height, better width, better bone. And as we know from Fickler and Hertzler's research, we don't want to elevate the flap. We don't want to damage the blood supply to the buccal plate. So again, tooth comes out. We saw the failed endo. Graft goes in. Place our implant. Add just a little PRF to help thicken the soft tissue, get a better emergence profile. Implant goes in, and in an area where we would normally have 30% vital bone, we have closer to 45% vital bone. So we're changing the biologic milieu by using a bioactive barrier. So now let's go back to Peter. We know that the bioactive barrier with an allograft can preserve volume. What can it do in a case like this? Calculus. Quick question. Have any of you ever had a lesion like this on the distal of 18 where you just kind of got lost on another tooth and didn't really see that at the time of surgery? I didn't treat that at the time of surgery because I kind of got so lost chasing all the infection of 19 that I forgot about it. So you're going to see 18 treated when I place the implant. So we know there's bone loss around. That's the HDMI cable. Just keeps blanking out. So we know 18 has a distal defect. We know 19 has defects everywhere. We know 20 has a major defect. Again, he's older, he has Parkinson's, he's going to have trouble brushing, he has trouble coming in. I need to do everything that I remember to do in one visit. And I need to use materials that I know will give me periodontal and alveolar regeneration. There's the defect on the distal of 20. There's the defect on the mesial of 18. That's not a simple regeneration, even though it's a simple extraction. Yes, we take off the crown, we section the tooth, we pop the roots out. Any of our oral surgery colleagues, any of our general dental colleagues can do that. But if they just leave a hole, they're losing this. Now the pocket's down to here, and the pocket's already here. What are they going to have left? So, crown comes off, fractured root, everything comes out, and we can see the defect even on the mesial of 18. So we root plane, and again we see the dehiscences. We see that gigantic pocket on 20. Again, not just a periodontal issue. That's the distal of 20, a little bit of bone, and then more dehiscence down below it. Who other than a periodontist is going to even take this much time to diagnose the issue? So that's what we start out with. And again, trying to do this in a dark hole. I'm not laying giant flaps because I don't want to damage the blood supply. So again, corticocancellous allograft because I want the volume to be maintained longer. I'm adding GEM21. I need real kick, whatever you want to call it, growth factor. I need way more than PRF would ever give me. Putting a piece of BioXclude on top, putting a piece of collagen over the top of that. Why in this case collagen, not PRF also? Because if it stays a little longer, I want to try and get a little thickening of just the coronal gingiva. Boozer and Grunder say 2 millimeters of bone. Linkevicius says 3 millimeters of soft tissue. I'm hedging my bet. But that collagen doesn't go under the flaps beyond the crest because I can't have it inhibit migration of the stem cells where we have no buccal or lingual plates. So look what we get from our 10 millimeter and 9 millimeter pockets. Because we followed McGuire and Shire's research, because we followed Nevin's research, we're down to 3 millimeters. We're down to 2.5 millimeters, where we had 9 and 10 millimeter pockets. Nobody other than a periodontist is doing that. We got the full ridge back. We have no infrabony pocket left. Real bone reentry. No infrabony pocket left. So now we're going to place the implant. I'm going to add a little PRF, a little graft to support the soft tissue, to give me a better emergence profile. I don't care if it becomes bone or not. I just want it there to give him the better ability to cleanse it. But now I said, oh crap, I forgot the distal of 18. So open that area. Debride, allograft with GEM21, and BioXclude is going around the distal and around the buccal. I don't have to trim it. I just have to cut it thin enough so it takes the shape I want. It takes 3 minutes. Not like the old days where we had to trim everything the right size. That's healed. That's where we started. First graft. First graft healed. That's where he started in 3D. That's how everything healed with the Gem 21 allograft and BioXclude. That's with the implant loaded, and that's with the periodontal graft done. Remember, there was bone here, infection all the way down to here. Nobody else can do this except us. Nobody else is going to pay the attention that we do to not only diagnosing the lesions, but cleaning them and treating them. So, what did I learn from Sig and Stu and Dennis? It's not only doing it that matters, but it's the biology. That's what the bone looks like. That is almost 70% bone in an area that's normally 30% bone. We've totally changed the whole environment by adding the Gem 21 and the BioXclude. That can last him forever. He'll come in every 3 months. As his home care deteriorates, what am I going to do? Have him in every 2 months. And that's probing, by the way, to blanching. That's really pressing on those. And all the way in the distal, 3 millimeters. Remember, it was 10, 9, and 7, those original pockets. So, Ephraim. The x-ray on the left was 1 year after I did a conventional allograft and collagen barrier. The one on the right is after COVID. So things will work if you have repair until they're challenged bacterially. So who's saving this tooth? Who's saving this tooth? Because the wisdom tooth is coming out. And if you save them, how? And if you don't save them, what are you replacing them with on someone who's already failed periodontal grafting? So that's what we have. We have 10 millimeters. We have 10 millimeters in the furcation. That's what he looked like in 2016. That was his pocketing. That was his pocketing 10 months ago. Whole maxilla deteriorated, lower left deteriorated. What do we know about periodontal disease? Site-specific, episodic. Nothing on the lower right changed. Lower right stayed healthy. So that's the upper left. We have really deep pockets on the whole upper, especially that upper left second molar. His gums look like garbage. What periodontist is going to do bone grafting or even extraction and socket grafting knowing the maxilla looks like that? So I'm going to first address the maxilla. I'm going to go in, I'm going to take my laser and root plane and use a laser protocol, not just one of my regular lasers that I can say I'm going to do laser-assisted root planing, but use one that has a published research, legally backed protocol that I can say may regenerate, or at least I know will have the greatest chance of killing the periodontopathic bacteria, which can not only prevent the spread locally, but may help prevent the spread systemically of disease. So that's what he looks like after the laser-assisted root planing, except for one little change here. So remember I said that the upper left had a really deep pocket? So the goal is I want to destroy the biofilm. I want to create hemostasis in those pockets to give me the best chance of getting fill. That pocket is 10 to 15 millimeters. Horizontal bone loss. I am not getting that. At my level of experience with this laser, I'm not getting regeneration. So I am going to place a piece of BioXclude in the mesial furcation of that upper second molar. That is not kosher. That is not accepted protocol, but I care about the patient. So I am in this area, right up here, sticking a piece of BioXclude. Because if I can't keep that molar, I'm not going to be happy. So that last piece showed that to the mesiopalatal was 15 millimeters of pocketing. So BioXclude, once it gets wet, 2 curettes, goes right up in the furcation. And then for those of you who use this laser protocol, I'm just doing my hemostasis in the coronal 2 to 3 millimeters. I'm not putting the laser all the way up in the pocket because I don't want to risk damaging the BioXclude. Now the bottom. We saw the pocketing. I'm taking out the wisdom tooth. Those are the holes. 10 millimeter infrabony, 8 millimeter infrabony. Is it predictable to save? If I take it out, I have nothing to replace it with because he's going to fail implants. So again, my ideal graft is going to be affordable and biologically acceptable and bioactive. So I'm going to take the wisdom tooth, grind it up, mix it with my allograft, and cover it with BioXclude. Angiogenic, osteogenic, anti-infective, growth factors, binding proteins. If anything is open, the body's going to seal over it. And there's going to be another piece going all the way around the distal of 18. And sutures. No supercorally positioned flap. I don't want to damage the blood supply. I don't want there to be scar tissue and tension that's going to pull the flaps open. That's 3 months. 9 months, the upper is looking better in front. Upper left looks unbelievable. Root planing laser. I don't know if I'm going to get regeneration anywhere else. 9 months, 3.5 millimeters. That was 10 millimeters to the buccal, 15 millimeters to the palatal. That was the initial pocketing on X-ray, and look at it now. All radiopaque. BioXclude and the laser with the accepted LANAP laser protocol. So what about the lower? 9 months. These pictures I took Thursday right before I left for the airport. So initial 12 millimeters on the mesial of 18, 4.6. Was it 5 months? 3.1, still moving coronally at 9 months. Distal, 10 millimeters, 4.5 millimeters at 5 months, 3.5 millimeters at 9 months. Still getting, creeping not only attachment of soft tissue, but gain in bone. Distal of 20, we start out with 11.5 millimeters, 3.6 millimeters at 5 months, 3.1 millimeters at 9 months, and more radiodense everywhere. Not something I would expect to see with any of my conventional periodontal grafts. The BioXclude gives me everything I need to get more predictable periodontal grafting. So, lower right premolar, is that a simple extraction? No, because of this. If I put an intermediate socket implant, do I put it here and risk losing that bone? Put it here and hope my magic foo-foo dust will give me attachment or adhesion to the distal of the implant? So again, allograft, PRF block, BioXclude. Matt, so hard to get that to line up. Very hard. Again, BioXclude, growth factors, binding proteins, anti-infectious. Not a flap. I'm just tucking it to the margin of the tissue. Not even adding anything over it. Remember, that was the original defect. We got a lot more bone just from that flapless extraction. All the extra keratinized tissue. Now we have the ability to treat this. Because once I have to elevate a flap to take out the tooth, I'm going to treat the peri-implant issue next door. Do I care if I get bone there? It's 90%, 98% in bone. What's the issue here? She has very thin soft tissue. So if I leave her with thin soft tissue, she's going to be at a risk for losing more bone. So my titanium brush, my air polisher, my tetracycline on that surface, PRF block covered with BioXclude everywhere, just like I did at the extraction. And I'm going to add PRF, especially on the lingual, to help thicken the soft tissue. But most important, I need to get the tissue sutured where I want it. You're not using a $2.33 suture scissors and needle holder from eBay for this. I like to use something that with 5-O-proline, 6-O-proline, 5-O-PGA is going to keep my flaps exactly where I want them. And Lachelle has the coolest cutters also, because do you ever get everything right where you want it and your assistant comes in with a chainsaw to try and cut the suture and now your flap is like waving in the breeze again? These are the coolest for that, because once they have just a bit of tension on the suture, they squeeze the handle together and it cuts like butter. So with these instruments, I can place all the tissue right where I want it and know it's going to stay there for the whole time that I have the sutures in place. So what did we get? We got enough bone at the extraction. I added more at the time of implant placement to treat the peri-implant issue. I'm using my active BioXclude barrier and my PRF, not because I care that it's bone on the lingual of the implant, but I want to give me the best chance of getting to Linkevicius's 3 millimeters of soft tissue. And I'm using my Lachelle surgical instruments to be sure that I get the tissue where I want it. So, last one. What do? How many are you taking out? You taking out 9 and 10? Unfortunately, I don't have a pre-op CT. I have no idea why. I checked my entire office 3 times. We don't have one. But we know there's no buccal plate, almost no lingual plate, no buccal plate here, and a tiny bit of bone there. So what do? If you take out both, what are you grafting with, and how many surgeries is it going to take to get the bone back? I'm not saving 10. I'm not crazy. All right, I'm crazy, I'm not stupid. But I can't save 10. But the question is, can we save 9? So Snoasis, the distributors of BioXclude, actually have studies where they've taken endodontically involved teeth and put BioXclude in the chamber and regenerated pulp. Not bad. So what do I tell the patient? We're taking out 10, you're going to lose 9. I'm going to do everything I can to preserve the bone volume and soft tissue volume, so when you lose 9, we'll be able to graft the site. My father, who was a dentist, said if you discuss something with a patient beforehand, it's an explanation. Afterwards, it's an excuse. So I want to go from the left to the middle to here. So let's do this quickly. That's my goal. So on the good side is not the PAP and the bone loss. On the good side may be a little piece of bone there if that's not calculus. Bad side is all the bone loss on 11. What the hell do we do? So we're starting flapless. This part was my mistake. I used a xenograft, a porcine xenograft, because I thought I wanted something very long resorbing, and the company that I was working with on this said it would resorb quicker than the bovine xenograft and would form a lot more bone. But you'll see what that looks like. I'm going to hydrate it in Gem 21, make a PRF block so that I have something relatively rigid to put in there. You see how much bone loss there is on the central, how much bone loss and recession there is on the canine. So where am I putting my BioXclude? On the whole surface of 9, on the apex of 9, and in the buccal flap. So I'm using one long piece on the distal of 9 and one other piece. So one piece goes up here and around, and another piece goes inside the dehiscence. Put the block in there. I elevate just the papillae, fill everything, BioXclude over the top. PRF is going to go over that just so she doesn't brush it away. There we go. So that's the hole, that's the graft, and that's her Essex retainer. So that's 6 months later. What do we see? We don't see a PAP. We see a PDL. No sensitivity, no pain, no discomfort. Oh. But the bone looks very thin, and there's still this. So I tell her we have to open it. I think I need to add more graft material, but we preserve the soft tissue volume, which is what we wanted. So when we open it, what do we see? We see full bone all the way up on number 9. We see most of the bone back on number 11. But now we're going to come back and we're going to do a secondary graft. We take out all the non-healed material, and we have a knife edge ridge. But we know we have good solid bone underneath. So we're going to take our allograft, hydrate it in Gem 21 again. We're going to use tetracycline on the roots after we root plane. We're going to take our BioXclude, put it over the top, primary closure. No PRF because I didn't want to risk delaying the stem cell migration this time. Sling sutures will help keep the tissue where I want it. 2 months later, we have that. So we got the full height and volume of soft tissue back. We got full root coverage. We got absolutely everything we need. Remember, the bone was here, and the bone was there initially. So using bioactive grafts, bioactive barriers, sometimes when I needed Gem 21, there's a lot we as periodontists can do if we diagnose and if we have the confidence in our treatment modalities. So with that, I am just about at the end. I think we've seen more than enough cases. Any questions while we get ready for round 2? So I'll start with number 2 and then go to number 1. So as I tell my students, there's never and never, never and always. I never add autogenous scrapings because I'm always afraid I'm going to get saliva or something else in there. The only time that I add bovine xenograft is when I use Ernesto Lee's SMART technique. So sometimes I'm adding the porcine, but after this case, I'm using it less and less. Again, you saw the results. It should not have handled that way. Anybody else? So the question is, am I doing the extraction and graft the same day? In 25 years that I've been doing simultaneous extractions, I've had 1 infection. And this would have been maybe the second. I always do. I don't irrigate the sockets. I use cold hard steel. I scrape and scrape and scrape, and if I'm concerned, I'll go in with a round diamond burr. Slow speed and just get to a bleeding surface. Always, 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 always. Where my office is, there are way more attorneys than dentists. Way more. And if they don't work there, they live there.
Did you start the antibiotic the night before then?
Just an hour before. Yes?
So how many cases do you have where you use BioXclude in the pocket after the laser and you've gotten regeneration?
So question is, how many cases do I have with the laser, with LANAP, with BioXclude? Only 6 or 8 so far. I mean, I'm finishing my LANAP certification in 2 weeks. So I've only been using this specific protocol for a year. And I wanted to really play with their protocol before I started going completely off the bandwagon. And I'm only doing it in frications for now.
Curious, because I've done a lot of Lanac with Indigate, and I've never thought about using BioXclude weight kit. So that's interesting.
Yeah, I used Emdogain for a long, long time, and we'll talk afterwards. Anybody else? Yes.
How did you restore this case that you discussed?
This was like 3 weeks ago. So in another 2 months, she'll get an implant and then a single tooth crown. I'm just waiting for it to mature. I don't ever like to go in too soon.